Today I will finish this great conference by addressing one of the most important issues that face older adults that leads to a lot of complications, basically, which is falls. Falls are a big issue because, first of all, they are common. Second, they are associated with significant costs, either to the person themselves or to the medical system. Today I'm going to give an outline about the approach to bipedalism, normal age-associated changes with normal age-related changes to gait, definition of fall, and differentiation between falls and syncope. Also, how can we actually assess falls in the clinic? The objective is to understand the evolution of bipedalism, identify and analyze age-related changes, and define, characterize falls, and establish a real comprehensive approach to falls, and finally, to identify and analyze the common risk factors associated with falls in the community. Why do I talk about pedalism? Actually, one of the most common says in geriatrics, if you want to prevent falls, you actually you have to focus on addressing why people fall in the beginning, and the reason why they fall is because they are walking on two limbs. Since we are walking on two limbs, it is an inevitable fact that people are going to fall. The importance, it's very important for us to understand why is it actually critical for us to be bipedal or walking on two limbs. There are multiple theories to explain that. It dates back to before the 20th century. Bipedalism is influenced by either, it works basically that bipedalism helps with the energy efficiency, heat regulation, carrying objects, long distance travel, and height advantages related to regulation of feet and so forth. And finally, using tools and improved ventilation. There are multiple theories basically dating back to almost like 3.5 million years that it was initially thought that humans used to walk on, were quadrupeds, for as to say. And with time and with evolution, basically the oldest fossil dates back to 3.5 million years back. The evolution comes with the evolution in the central nervous system, as well as our reflexes and the musculoskeletal system. Falling and postural stability actually requires all interaction at all these three layers. So we are talking about higher centers, we are talking about the neural rhythms in the spinal cord, as well as the development in our and distribution of muscles in the musculoskeletal system. And I'm going to skip that slide as I spoke about it. As we grow, focusing on like our early childhood, initially we put a lot of energy to prevent falls. So that's why children or like babies, when they walk, they put a lot of effort and they walk with wide gait, and that's to minimize the risk of falling, and a lot of energy goes into that. And with time, as they develop their neural reflexes and they develop the CNS system and the postural control starts to develop, then they direct this energy to being an automatic behavior and they put that energy elsewhere. That's also important because as you can see, as we age, all the degradation in the other systems puts a lot of effort, and then you start to consume a lot of energy, and then you have to think about all the steps. So it's just important for you to understand that this process we go through it in early childhood, and then with time it kind of gets reversed as well. So what happens with aging? With aging, you get to have a lot of changes that affects gait and balance. So basically, all the other experience changes in, like they become slower, their steps become shorter, and then they will have more stride variability. They will also have a lot of reduced balance due to issues with stability. With the musculoskeletal system, there is a lot of changes related to atrophy in the muscles, and as we note, sarcopenia, which can go hand in hand with osteoporosis as well, and decreased flexibility in the joints and affecting the hips, knees, and ankles. With the CNS, you will have also slower reflexes. Aging also leads to a lot of changes in the motor control in the CNS system, as well as the peripheral nervous system. So you also have sensory perception troubles related. So basically, you have either delayed reflexes, but you also have changes in perception and either in the upper and lower extremities, which definitely affects the biofeedback and the feedback that you get from the feet to the knees, and the proprioception, which definitely increase the risk of future falls. You also will have changes related to vision and hearing, which plays a major role in postural stability as well. So with aging, we also have a lot of changes related to gait, as I mentioned earlier. So you can see in the lower part of the slide, the common changes related to gait, including decline in walking speeds and step length, cadence, as well as the step heights as well. So all these changes increase the risk of falls, and it has to be assessed during your regular and routine assessment. So what is the definition of fall? So the definition of fall is it's an event which results in a person coming to rest inadvertently on the ground or a floor or other lower level. So that's the technical definition of a fall. Falls are different than syncope, and it's important to differentiate them because a lot of mix-up happens in our assessment, and so there's a great difference between the two, and during your assessment you have to be able to differentiate both of them for a proper assessment. Syncope, on the other hand, is defined as a transient loss of consciousness due to cerebral hypoperfusion characterized by rapid onset and short duration and spontaneous and complete recovery. So why do we actually care about fall? And that's what brings us to the second part of this lecture. Falls are a big deal because they are basically we have almost 684,000 deaths or fatalities annually from falls. They cost around 50 billion almost annually as well, affecting, depending on which country we're talking about either the European Commission or the United States or North America. More than 80% of falls, more than 80% of falls-related fatalities occur in lower and middle-income countries, particularly in Western and Southeast Asia. And globally, adults aged over 60 are the most, they are the one who incur the highest and the largest death rates due to falls. So non-fatal falls lead to medical attention, which requires around, which causes around 3.7 million cases annually. Falls also cause a lot of disability-related adjusted life years, which can have additional costs to the medical system as well as the person themselves. Those who suffer disability, mainly older adults, they are a significant risk for long-term placement and institutionalization. In Saudi, we don't have a lot of long-term placement, so that means a lot of cost on families and caregivers, which definitely have a lot incremental costs. The financial costs, as I mentioned earlier, we're talking about 50 billion annually in the States and 25 billion when we talk about the European Union. So it is a big deal, and we have to address it as a significant problem. When we talk about the epidemiology of falls, so nearly 50% of individuals who experience a fall will encounter another fall in the next year. So repeated falls are a big problem when it comes to people who fall. Although the majority, they don't lead to problems, around 30% of them result in injuries as well as medical attention. So that's how you get the incremental costs associated with them. Around, like basically 10% of those who fall, or from 1 to 10%, they will have a hip fracture, which definitely is a big deal. We're going to talk a little bit more about the frequency and the prevalence of falls in older adults. But again, I know it might sound like a lower rate, but when you have repeated falls and high prevalence, that means that it is a big deal when it comes to fracture. So women are at 50% more likely than men to have falls, and we do have different rates and prevalence of falls in different settings. So when you talk about the long-term care or acute care settings, the rate of falls are different when we look at it from that perspective. So among nursing home, the incidence of major soft injuries and fracture is almost twice as high when it comes to the basically complication related to falls. Just recently, we made an analysis, like basically in-house analysis in the ministry, and I would like, maybe this might be for us, it's still not official, but we do have a different trend when it comes to the fatalities related to falls, and maybe when in a closed session we can have a discussion about it. We just did that analysis last week, showing very important results related to deaths related to falls in Saudi. So to just have a look about the difference between syncope and falls. So as you can see here, syncope is basically defined as transient loss of consciousness. And we do have 3 categories of syncope. And I just want to make it basically highlight that again, that a lot of people sometimes mix up syncope and falls. But there is a huge difference, and the complication and assessment related to it is way different. So teasing out this during your assessment is very critical. So we have 3 major categories when it comes to syncope. We have the orthostatic or reflex syncope. We have the cardiac causes, which can basically be either structural, electrical, or others. And then you have the other than the cardiac syncope, you have the orthostatic syncope, so orthostatic related hypotension and so forth. On the other hand, you need to differentiate between syncope and epilepsy. So because it's also not defined either as syncope or as falls, so it's very important to make that differentiation, and I'm going to talk about it a little bit in the next slide. So what is the difference between syncope and seizure? So there are key features that you can make from your assessment and history. Basically, seizure can mimic syncope and can cause falls. But one of the most specific signs that you can differentiate is the lateral tongue biting, which is almost as 100% specific. You also will have some elevated vital signs like elevated heart rate and blood pressure, lateral gaze deviation, which can also help you differentiate syncope from seizures. You can look at this basically table here to help you basically make the differentiation between syncope and falls. Again, why do we care about falls? They are associated with decline in functional status, so people becoming more dependent, therefore requiring more assistance at home, increasing placement in long-term care, greater use of medical services, increased hospitalization, length of stay, and hip fractures, which definitely are associated with significant health and financial costs. A substantial proportion of hip fracture are caused by falls, and a significant number of community living older adults will sustain a hip fracture. However, it usually depends on prior functional status. So if people who are bedbound, they're less likely to incur falls and less likely to incur fractures. However, it is very important to also address the functional status of the patient. So after a fall, 25% of older adults will restrict their activity, and will actually not restrict or seek medical attention. More serious injuries, including fractures, joint dislocations, sprains, strains, occur in, as I mentioned earlier, 10% of those folders. Rhabdomyolysis, which is associated with prolonged falls, also can lead to significant issues. But the one that I really wanted to stress on is the fear of fall. So if you incur one fall, especially for older adults, it's really hard for them to regain the confidence, and then they will alter their gait, they will alter their let's say, lifestyle, and unfortunately, that alteration modification sometimes are maladaptive and will cause a future fall. So fear of falling is also a psychological and a common problem that older adults face after the first fall. Luckily, in Saudi, we're having a lot of publications related to either the prevalence or the complications or the association of falls, and this is just some of the recent publications. Moving forward, I just want to emphasize that falls doesn't happen like as a single event. They are always multifactorial in nature. They're usually a precipitating environmental factor and a predisposing intrinsic factor, as well as extrinsic factors. Medication plays a huge role in the cause of falls, and the interactions between all these factors also are very important. I told you earlier I'm gonna show you what are the prevalence of falls and why it's a big issue, and it should always go hand in hand when we talk about fractures and osteoporosis, because that's the risk factor for future fractures. If you are almost as 65 or 60 years old, your probability of fracture is more than 27%. That's 30% annually. And if you have more risk factors, then that prevalence and percentage increase incrementally. So the other thing is that the probability of future fall, if you have one more fall, is 10%. So you add that, and it becomes like a huge issue. Basically, as you can see from here, these are the predictors of future falls. And that's based on retrospective analysis. So depending on with the highest likelihood ratio, having dementia or cognitive impairment is a significant risk factor for falls. Having difficulty rising from a chair, history of a previous fall in the last month, and that's why it's always incorporated in your daily regular assessment for all the adults. And then self-perceived mobility problems or abnormal stand. So these are the factors for predicting more than one fall next year, with, again, dementia being the highest. That's why when you care for someone with cognitive impairment, it is critical as for a best practice assessment, you really need to ask them in each visit, especially like at least once annually, about their previous falls. So frequent falls in the past year, and this is the article where most of the guidelines they drew the recommendation from regarding the annual assessment of falls, or asking, have you ever fell in the past year or so? So as I told you, the assessment of falls depends on assessing the intrinsic and extrinsic risk factors. When it comes to the intrinsic risk factors, I put them in order from the highest odds ratio to the lowest. So it starts with muscle weakness, history of falls, as I mentioned, gait abnormality, and then using assisted devices and visual defects, impaired activities of daily living, cognitive impairment, and being older than 80. So that's an order of highest odds ratio. So if we want to address the risk factors with the highest odds ratio, then I think addressing muscle weakness, previous history of falls, and gait abnormality is an important target to address. When it comes to extrinsic risk factor, it depends on the setting. So at home, having like clutter all over the place, having basically uneven carpet, unstable furniture like either chairs or rugs, Slippery floors, poor lighting, and low toilet seats are risk factor for falls. And they also change. So when you assess like institutional related falls are way different than home or community related risk factors. And so basically you need to address, for example, the heights of toilet seats in the hospital or acute setting, slippery floors, poor lighting, which happens especially like in different wards in the hospital. So you need to basically do your own assessment and capture what are the risk factors there. So as I mentioned earlier, when you assess falls, risk factors, they don't happen in isolation. They usually accumulate. And the accumulation of risk factors increases the prevalence and the future likelihood ratio of falls by dramatic falls. So if you have more than one, so basically if you have more than 2 to 3 risk factors, your risk of future fall is around 60% and reaches up to 80% if you have more than 4 risk factors. So that's called the risk factor accumulation principle, and then it works really significantly when it comes to assessment of falls. What are the most common causes of falls when you ask older adults and when you reassess them like time and time? Most of them, they will say it happens as an accident because there was environmental related changes, or they slipped because of like an uneven furniture or rug. Having gait and balance issues are the second most common cause. That's all reported by older adults. And dizziness and vertigo being the third most common cause. So what do we do actually in our assessment? In our assessment, as I try to convince you, it's always a risk factor doesn't happen in isolation. So what we do, it starts with screening, and then you go into assessment. So there's a difference between screening and assessment. Screening is usually something that helps you identify people who are at risk, and then you do and conduct your comprehensive assessment. The comprehensive assessment starts with a medication review, especially looking at psychotropics or any sedating agents. You do basic functional assessment, orthostatic and blood pressure measurement, vision and gait and balance exercise, cognitive assessment, and you end up by doing home safety evaluation and assessment if you can. So the medical history, the rule of 3 S's, that's to rule out syncope, as I tried to explain earlier, rule out seizures, because these are really serious basically conditions that requires further workup. And then you rule out serious precipitating medical illness, because in older adults, they usually present with a fall as their atypical symptoms. So in my clinic, I always see people with pneumonia presenting with falls, heart failure and heart attacks presenting with falls, malignancy also presenting with falls. So it is one of those atypical presentation or atypical symptoms for a serious injury. So please don't dismiss it and always do like a thorough workup. You need to start by asking why, where, and how, reviewing the circumstances around fall, the location, the time, the activity of fall. You assess the complications, so you always ask for the causes and then the complications of the fall. So basically any type of injury, duration of lying on the ground, causing rhabdomyolysis and so forth. You also assess the frequency of fall happening in the last 6 months or 3 months, and then you see the associated symptoms. We also do, as I mentioned earlier, the functional assessment and the medication review. In your physical exam, particularly, you're looking at the vitals, postural vitals, vision and hearing assessment. And your cardiovascular assessment, you want to rule out postural hypotension. Cognitive assessment and CNS assessment, you want to rule out Parkinsonism presenting with instability, which is also very common in older adults. And if you have the time, you do a gait assessment and posture. A falls assessment cannot be complete without a gait assessment. So for special tests, like in the clinic, we usually do the time up and go test, the Berg balance test, and the functional reach test. We also do the Romberg's test and short physical assessment battery, and I'm just going to explain maybe in a very superficially about these kind of tests. In inpatient assessment, we do have different screening and assessment tools. We have the Morse scale, the Hendrick Falls risk model, and Johns Hopkins, Teneri, Stratify, Schmidt. We also have other tools, and in each, also in the Ministry of Health, I think they are, in Saudi, we use the Morse scale. It was published, I think, 2 years ago. So if you have time, maybe you can look at it on the website of the Ministries of Health assessment. But you really need to know the difference between each assessment tool and screening tool. You also need to understand the difference and the validation between these tools, because they are all based on retrospective analysis. They have some issues related to sensitivity, specificity, and predictive validity. Okay, so when it comes to the primary care setting, we have multiple tools out there. You just need to be familiar with any one of them, but just the short story is that most of them, they don't have good diagnostic accuracy, basically having a diagnostic AUC or area under the curve of more than 0.7. So from that analysis, basically asking the patient if you had a fall in the last year or 6 months is as good as doing most of these, let's say, screening tools. But you just need to be familiar with one of them and get and basically be good at it and use it to basically do your comprehensive assessment. So the functional reach tests, usually you can, it basically helps you assess the gait of the individual. It can be easily incorporated in your daily clinic routine, as you can see from the picture here. The short physical assessment battery takes more of a time. It's more of a specialized kind of assessment done by physiotherapists, so you just need to be aware of the components of that. I basically use that in my clinic, but again, it takes a lot of time, so it's handy to have a trained physiotherapist in the clinic to help conduct these tests as you're basically waiting for the patient to see you. The Berg balance is more of a sophisticated gait assessment, and as you can see, it takes around like 10 to 15 minutes to conduct. The time up and go test is one of the easiest. Is basically you put a patient in the chair, you ask them to go like walk 3 meters, turn and come back, and you have different measures depending on age. You just need to be familiar of the different cut points. However, we usually use more than 12 seconds as the cutoff for future risk of falls. And then you have the sit and stand. So you ask the patient to sit in the chair and then get up 5 times in 1 minute. And then you calculate the time needed to complete that. And it has basically normal or normative values for different age cut points. When it comes to gait assessment, you need to be familiar with the different types of gaits. I'm not going to explain it here for the sake of time, but the most important ones are the antalgic gait, which is basically associated with pain, the high steppage gait, and foot drop gait. You also need to be familiar with the festinating gait, which is associated with Parkinsonism, and the en-bloc turns and magnetic gait, which happens with normal pressure hydrocephalus. So a lot of the time, these gait abnormalities are also associated with a serious medical conditions that requires further management, and it would require familiarity from the physician to appreciate these different types of gaits to help provide the appropriate treatment for the patient. So are we good at preventing falls? Actually, most of the studies that looked at the Cochrane reviews that looked at preventing falls, when you look at a single intervention, it really doesn't work. If you look at interventions that focus on multifactorial interventions, it kind of works. Exercise works when the patient is doing the exercise, but when they stop, the risk of falls increases. So as you can see from here, the multifactorial risk management is associated with basically around 20% risk reduction, and that's when done in the community. When we look at the long-term care and institutionalized programs, as I mentioned, it is a high area of focus right now, and especially in Saudi. And unfortunately, I got to know that most of the deaths happens in hospital, or at least that's what's reported. So we really need to have national programs focusing at the deaths related to falls and fractures in the institution. And as you can see, multifactorial intervention can reduce the rate of falls from like 306 annually to 204, and the rate of falls per person from 6.1 to 1.6. So it does work, and we should look at interventions to reduce the risk of falls. So after you find someone who have risk factors, and that's where the deficiency maybe happens, is that, okay, what happens next? So you have a lot of algorithms and guidelines to help you. And if you don't have a geriatrician, rheumatologist, and people who focuses like physiotherapists and people who focuses on falls and fracture management, or systems or model of care, such as a fracture lesion model, you basically need to build the capacity for most of the staff to address and manage falls or falls risk factor. First, after you define or identify someone with risk of falls, you refer them to either a geriatrician or an internist to conduct a comprehensive geriatric assessment. As I mentioned, you always find things in aggregate. You always find more than one thing that causes these falls. And as I mentioned earlier, there are areas and risk factors that have higher odds ratio that you can focus on, and especially like medications and polypharmacy that needs to be addressed. So you can follow this algorithm, and I think this was published in 2022 or 2023. It's the world guideline for prevention of falls for all the adults. These kind of models has to be incorporated into the system for a successful implementation. Otherwise, we will identify high risk fallers without appropriate follow-up and management. So the takeaway message: falls are common, they are complex. Falls, basically, they happen commonly. It's a common occurrence in older adults, and they are complex process. Understanding the multifaceted nature of the falls, including age-related changes, is crucial for effective prevention and intervention. Multidisciplinary intervention and assessment are essential. Preventing and assessing falls require a multidisciplinary approach, as well as including the right allied health team to help you with the future assessment and management. Thank you so much for inviting me today, and I wish you a successful event.